Welcome on the day before a holiday. I appreciate you all joining us, and hopefully you're all getting prepped for Thanksgiving tomorrow. We are recording today's session. We do store those on our Canvas page as well as our YouTube channel. So you can always go back and watch those, share them with other colleagues. And if you're anything like me, it takes me a minute or two to hear that information and digest it. And so I want to be able to go back and review it. A huge shout out to the Autism Council of Utah and the license plate for providing this funding for that project. This project, they are just a great organization and support throughout our state to support individuals on the autism spectrum. Key components of an echo session, if you've never joined, is that we really are encouraging that professional networking. So if you feel comfortable, turn on your camera so we can see each other in this virtual world, so that if somebody says something that is really wonderful or you wanted to hear a little bit more. I know Amy Nance's name just came across my chat. I would know that I could reach out to her if I had questions about children with special health care needs and how do I connect with her. Also, we will always have a didactic speaker or a speaker who shares some information with us. Today, we're really lucky to have Dr. Chuck Edgington to talk to us about the early indicators of autism. And then we will have a case presentation where we have somebody present a case, and then all of you amazing people on this call get to share your ideas and solutions on how we can work with this kid or this family. So please be interactive. Put your questions into chat. Raise your hand. We have Colin Kingsbury, one of our amazing hub members that monitors the chat for us. So we'll make sure that your questions get answered. Again, case narratives are just a great way to hear from everybody on this call. You know, when we're out in the real world and we're talking to families or we're working with clients, sometimes we get stuck on what to do and how to make sure that we're doing what's right for these kids. And so the case narratives are a way to get a ton of information. So please consider doing one of those. We do talk about families or clients or providers or whoever we're talking about on the call. We just want to make sure we're providing or protecting their privacy. So try not to use their first and last names. Don't use their family's names. De-identify. If you have any questions, please reach out to a hub member. They do have an asterisk in front of their name, so they're easier to find. We've all been on Zoom for a while, so we know how to change our, rename our profile. Again, that just creates another way so we know where we can reach you or where we can find out how to connect with you after this call. Raising your hand, again, you can put the comments into chat, raise your hand. Colin, again, monitors that for us. In order to get a credit or a certificate of attendance, we do ask that you complete the survey. Throughout today's session, we will be dropping the survey link for you to complete. That just then is able to help us change anything that we need to do based on your guys' feedback. Canvas is where we store everything. So if you would like access to Canvas, you can email us at autismecho@aggies.usu.edu and we will get you access to our Canvas page. Case studies, again, are just a great way. I know it's sometimes nerve-wracking to share a case or a client that you're working with, but the amazing information that you get and take back are is just fantastic. I've done a few of the case presentations, and I can't tell you all the amazing things that you guys all come up with that I can then work with that family the next time I see them. Um, we always store the recommendations for every case presentation on our Canvas page. So you all can also go back and get those recommendations that we send to whoever presents that case for us. We do have social media, so if you want to take a minute and follow us on social media, that would be great. And then I'm just going to do a reminder that in December, our next session is actually on a Thursday, December 19th, because of the Christmas holidays. So hopefully you'll be able to join us on that one. I am going to now stop sharing and turn the time over to Dr. Chuck.
Very good. Thank you so much. I appreciate the opportunity to present. It looks like my microphone is on, so I'm assuming people can hear me. If that's not correct, let me know. Um, Let me just start with a little bit about myself, and actually one quick question, Janelle. This is scheduled until 1. Am I supposed to go right up to that, or do you need me to stop sooner than that?
So you can go right up till 1, and then we'll turn it over to Joseph, who will be doing our case presentation today.
Okay, sounds good. Just wanted to make sure. Um, Let me just share just a little bit about me. That's okay. So, you know my name, Dr. Chuck Edgington. Currently in private practice in Salt Lake City. I am in a practice with Dr. Natalie Roth on similar another psychologist. Similar, she and I have a very similar background and training. Both of us trained in child psychology and then have spent most of our careers in the field of autism evaluation and assessment. I have a specialty in neuropsychology as well. Um, and so some of my evaluations will include, some degree of neuropsych assessment. I don't usually do a complete neuropsychological evaluation. It's not always of doable, frankly, from a time perspective in the system, the model that we have. But we do provide comprehensive evaluations to people across the lifespan. So I think the youngest person that I've ever evaluated was about 14 months, and the oldest person that I diagnosed was 60. And so in the current practice, we probably see mostly people under the age of 18, but we do see adults as well. One of the things that we do in our practice that has actually been very rewarding is we'll see sometimes an entire family. Obviously there's a pretty strong genetic linkage to autism, and so often we'll start with whoever the family's most concerned about, or the providers or whoever gets referred in. But we try to make available the services that we offer to any member of that family that might need it, that might have autism that hasn't been recognized yet, and help them in that way. And a lot of times, I think that's pretty empowering for parents who themselves are autistic, many of them, and don't know it, or did know it but didn't have confirmation. And so anyway, that's just been something that's very rewarding for us as well. So let me just kind of also say at the outset, there's a number of us on here, but I would love it if you guys would ask questions, and I will happily answer those questions. I would actually much rather do that than just talk at you, for the next 50 minutes. And so please ask questions as we're going along. I'm happy to pause midstream and respond in real time. We'll kind of monitor those. Probably chat is maybe the easiest way, to do that. But Colin's monitoring that. I'll kind of try to keep my eye on it as well and respond as much as we can. I really want this to be something that works, and kind of fills whatever needs are in the group that we have with us today. So. Um, So, having said that, if you've got questions already, start loading them up in the chat, and I'll monitor. We'll do that as we get going. What I'm going to speak about today, what they've asked me to talk about, is kind of early identification of autism symptoms in basically in toddlers, young children, and so that's where I'll focus most of my comments. But I'm happy to entertain questions outside of that scope as well. So let me know. Um, and hold on just one second. For some reason, okay, there we go. So a few learning objectives, understand, just kind of making sure everyone has a baseline understanding of autism, the diagnostic criteria. I'll just kind of blast through that. If you need it slower, let me know. But we'll talk about recognizing early signs, developing strategies for screening, and we'll talk about referring to specialists. I think one of the things that what they asked me to speak to is how do we know where to send people, and so I can kind of we'll talk about that a little bit as well. So I'm assuming that people know the basic criteria for autism. We know that it's largely composed of two major um, categories of social communication difficulties and restricted interests or repetitive behaviors, and that include, sensory challenges as well as inflexibility, together with, kind of the more thought of aspect of that, being like a stereotyped interest or a high interest topic, things of that nature. Um, we know that autism begins in childhood, and we know that it lasts throughout life. The importance of early diagnosis, really, obviously, I don't think it can be overstated. Early diagnosis leads to better outcomes, earlier access to intervention. As I mentioned, autism. I think the youngest child I diagnosed was 14 months of age. Um, and part of the reason it was so young was because at the time I was working in connection with a preschool program that was it was a research program from out of the University of Oklahoma where I was living at the time, and so they had a really cool intervention kind of model, and they were trying to catch kids at the very earliest times possible. And so it's not common that in regular clinical practice we would get somebody quite that young. But I do relatively often, I should say, we do see 2-year-olds with some regularity, which is good to see. Happy to see a 2-year-old and kind of get to this answer at that as early as possible. We know that delays in diagnosis, can create a variety of challenges, and we see that every day, in our practice, and sort of depends on other life circumstances. It's not just the fact that they're autistic and undiagnosed that might result in increasing difficulties, but in some ways or connected to that autistic condition, and not knowing it, that does sometimes lead particularly to increases in things like anxiety and depression, particularly in adolescents, and especially in like young adolescent girls that have been undiagnosed. Anyway, so the point is early diagnosis gives us access to, improved understanding for in both in their community, in their peer group, in their family, in their school, and all of those people being aware of those needs and then proactively addressing them kind of prevents some, at least, or helps to mitigate some of the additional challenges that might come along down the road. One quick question. Somebody said, "What's the wait time for a family to be seen in my practice?" So I'm going to share this piece of information with you, but you have to promise not to blast this on Facebook, okay? So, Natalie, Dr. Roth and I spoke at Critical Issues a month or so ago, and so we actually kind of intentionally are flying below the radar because it's just the two of us. And so we're happy to see as many people as we can, which usually turns out to around 250 a year, or so. So we're very, very busy. But currently, well, the holidays pushed it back a little bit. Right now, our intakes are scheduling at around 6 weeks from now, with testing being scheduled roughly 4 weeks after that. So we're roughly 6 to 10 weeks. And we're in and we've got, got the whole process moving forward. So um, all right, let's move on to the next slide. Just a quick update on prevalence. This was from the Atom Network, 2023 data, 1 in 36 uh, children diagnosed. Well, people, yeah, children diagnosed. I don't want to speak too much of this because I know Colin can rattle this stuff off the top of his head, but so I don't want to misspeak. But prevalence is still higher in boys than girls. Um, One thing I'll say is that I think some elements of some people in the field are getting better at picking up on female autism at younger ages. And so, fortunately, we are seeing even younger girls being, referred for our services, either from providers or from pediatricians in some cases, or just parents being more aware. And so we are seeing them. Nuanced presentations in girls, I think, are still harder to pick up on. And I think probably, I don't have the data, my own data at the ready, but I think it's not uncommon for us to see um, you know, probably older than third grade, before they get referred, before they're seen, by us, or, at least in my experience. And so definitely some room to grow there, I think, in terms of figuring out those more nuanced presentations. And I do have some things that I'll share with you today about that. Um, Let's see what else. Yeah, that pretty well covers more or less what I said, and I'll come back to subtle presentations here in a minute. So early signs in infants and toddlers. And again, I want to kind of get us thinking about um, kind of obvious things, what we sometimes now think of as like red flags, and also less obvious things, more nuanced presentations that we sometimes refer to as pink flags. Not our terminology, but there was a really helpful article written a few years ago that talked about sort of this dichotomy of like there are some really obvious things that most people can pick up on and trying to be aware of those, but also trying to be more sensitive to the nuanced presentations. So, it could be something obvious like they don't respond, to their name, or they respond differently, to different kinds of sounds, but maybe they don't respond as well to their name. They may be delayed in their language and development. May have difficulty following instructions, for example, things like that. Maybe they don't engage in pretend play or understand certain aspects of social gesturing. Again, we're talking infants and toddlers, right? So under 4, basically, in this on this slide. Um, but there are other sort of more subtle presentations. So it could be that the child actually does have a language and they speak just fine. Some girls in particular are hyperverbal, and so they acquired language early. Um, and they are quite skilled at, at least using language. And so then you might begin to focus something on that's more subtle, such as a lack of reciprocity in how they use language when they're communicating. So maybe not responding as well to an open-ended question, for example, needing the person who's communicating with them to kind of guide them through the conversation by asking them more direct questions. One of the things that I often ask kids when I first meet them, it's not, I don't do it to be mean. I do it because I'm evaluating them, but I'll ask them, can you tell me about yourself? And they just freeze. It's too broad of a question for somebody on the spectrum to respond to. And so it's something even as subtle as that can be an indicator. Difficulties with nonverbal communication, such as gesturing or personal space, challenges in developing age-appropriate relationships. That's a core diagnostic characteristic. And so what happens is the other subtleties, difficulties with awareness and reciprocity and reading social cues often results in, not developing age-appropriate relationships. In a toddler, this can look different ways. It could look like, um, you know, someone who's, parent says, well, yeah, they play all the time, with their siblings or with their cousins, or we've got a family friend, and yeah, they always play together. They seem like they're having a great time. Okay. Um, I've heard that a lot, and still the diagnostic conclusion was autism at the when the whole evaluation was completed. And what happens sometimes is um, children have the appearance of playing together because they're playing in the same sphere. So they're all running around, they're jumping on a trampoline, or they're riding a scooter, or they're chasing each other, or other things like that. And it's not that there's no social quality to that at all. It's just that type of play is much easier to engage in because it doesn't really require much in the way of reciprocity or turn taking or sharing, for example. And a lot of times, that's where you see more deficits is when it comes to can they do something actually together that requires coordination and cooperation. Sometimes that's where you'll start to see more difficulties. They may have milder in terms of repetitive behaviors, some of those can be less noticeable. So it's not, the obvious, maybe hand flapping, for example, or rocking, but it could be something much more subtle that presents, that you really have to watch closely for. Sometimes I will notice a child walking on their toes, for example, and I'll ask the parent, do they walk on their toes a lot? Like, no, I've never seen that before. I'm like, they did it here, and so I'll say, well, maybe just kind of observe that, pay attention to that. Sometimes, like walking on toes is an indicator of motor, like a gross motor issue. Sometimes it's a sensory issue. The child's feet don't feel comfortable flat on the surface, and so they walk on their toes instead, things like that. All right, let's continue on. Um, Sometimes we think of children who have less obvious presentations as being sort of high functioning. Um, and so that sometimes then the child is just sort of perceived as shy. They may have certain sensory sensitivities or rigidness that's not recognized, as being that, or they just say, well, that's just how they are. This just what that's just this particular child is that way. Um, and so and the other kind of this other issue of sort of high functioning, those of us in the field that have been doing this for a while, um, we try to steer away from using terms like high functioning or low functioning, partly because that some people, parents, they don't feel that that adequately describes their lived experience, or even an adult or older, teenager, even with autism. You say, well, you have high functioning autism, and the implication is that that means they're doing really well, in a number of things. And sometimes that can fail to appreciate that it actually can be quite challenging to be autistic, even if the presentation itself seems less obvious to other people. In fact, in some cases, some of the young girls that we see, um, really quickly speaking to that issue, um, they're exhausted. Part of the reason why they're anxious and depressed is because they're exhausted from masking all the time. And so we have to kind of just be aware that these less obvious or less noticeable presentations that doesn't always mean there aren't any impacts, on the person's functioning. A quick slide on why it's important again, to get these things figured out as early as possible. Um, if we're missing things, they're not getting access to services. If you kind of think of the flip side of these, if they're not getting diagnosed, they're missing services, their resources are, ineffectively used. They're not able to advocate effectively. Their relationships don't develop as well. All of the things that are on this slide. But if you flip them in the reverse, having an earlier diagnosis means they have access to better services. They have more effective use of the interventions that they are receiving. They're in a better position to advocate. Their relationships are likely to improve more because their skills are improving faster. So and so we try to, emphasize there are a lot of positives that come, from having an early diagnosis. So, Colin, I'm going to pause because you raised your hand, and it sounds like maybe there's some questions to address.
Yeah, it looks like we got a couple great questions here. The first one is, by what age do you see masking in girls?
Um, that's a great question. Probably, I'm trying to think if I've seen it. I don't know if I've seen it in a preschooler, but I've definitely seen it as young as probably kindergarten age. I don't think a girl isn't necessarily aware at that age that she's doing it. So it's not always entirely proactive. I think sometimes masking comes in the form of a child who is maybe anxious by nature and doesn't want to get in trouble or doesn't want to be perceived as doing something wrong. Maybe they've got a sort of a perfectionistic tendency, and so they really try to do everything right. Or they're really sensitive to criticism, and so they don't want anyone criticizing them, much less a school teacher, for example, or grandparents or things like that. And so they basically they have the ability to kind of bottle up any overreactivity that they might otherwise have, things that are frustrating, things that are causing them negative emotions, and they just kind of stuff it all in. And this, you can pick up on this when a parent says, I don't know what's going on. The teacher says everything's fine at school, but I'm telling you, they get in the car and they're melting down the second they get in the car. That's not because the parent did something wrong. It's because the child's been bottling all of that up, during the whatever period of time they were in that situation. So I've definitely seen it as young as kindergarten. And the issue is the longer people do that, particularly if they are doing it to avoid negative evaluation by others, that really can generate increasing levels of anxiety and to some extent increasing issues with depression and other issues over time. So it's a great question.
Awesome. And then the next question we have in the chat is, in families where multiple members are diagnosed with ASD, would you say that parents who also have ASD are more or less likely to recognize the signs of autism in their children?
Yeah, great questions. To be honest with you, it can go either way. Um, we definitely see families where we can tell that the parent is autistic, just because we can see it, and it's evident in the way that they interact. Um, and yet that parent sometimes perceives the child's behavior as normal because that is their experience also. So they're like, well, I do that too, or that they're just like I was when I was a child, for example, I had the same issues or what have you. Or they may say, I still have that issue today, but they're not always aware that the things they're saying that feel normal to them are actually characteristics of autism. Um, but on the flip side, we definitely have had parents who, on their own journey, have maybe they're not yet diagnosed, but they've been researching it, and they're like, I think I'm on the spectrum, and that effort on their own part led them to recognize, oh my goodness, my children are doing the same things that or having the same types of challenges that I have. I think I'm autistic. I bet they're autistic. And oftentimes, what happens then is they will refer the child to begin that process. It's actually, um, you know, moms are awesome. They'll wait till the very end, till all the kids get evaluated and they've made sure that they're fully taken care of, and then they'll say, "Okay, now it's my turn." And in some cases they refer at the same time. They're like, hey, I want you to evaluate two of my children and me. Like, great, let's do everybody at the same time. Let's get it going. And that's happening frequently in our practice. And we love to see that. We do still occasionally have those parents where we can tell the parent is autistic. It's pretty obvious to us, but it's not obvious to them. And so we usually will find a very delicate way of kind of having that conversation about genetics and the potential for these things to exist in other family members, um, and kind of with the goal of helping raise that person's awareness enough that they can maybe seek out their own services at some point, in the future. Sometimes they come to us and sometimes they don't, and maybe they find it elsewhere. And sometimes they go away for 2 years and then they come back and say, hey, I want you to diagnose me now. So anyway, those are great questions.
And then we do have one final question before we jump back in. What term would you use in place of high functioning to more adequately describe your patient?
So we use terms like nuanced or less obvious. Sometimes we'll just use the term less obvious. Um, because it sort of speaks to this issue of like, the person may in fact be experiencing a number of challenges, in some case significant challenges, um, even though the condition of autism itself may be technically described as kind of mild, because we try to avoid even the term mild sometimes because one of the things that we sometimes talk about is having quote unquote mild autism doesn't always mean you have small problems. I mean, people can really experience pretty significant challenges despite the condition itself being, what the terms that I think many people in the field now are using is either less obvious or nuanced, presentations, things like that, terms like that indicate that it's something that you have to be more perceptive of in order to be able to see it, basically. And I will say, let me just pause and say, that's not without some degree of controversy. I'll be honest with you. There are some providers in the field who think that people like us that are open to this more sort of nuanced presentation are over-diagnosing it. And my way of speaking, addressing that concern would be to say it's not that I'm diagnosing something that doesn't exist. We're diagnosing something that's not obvious to many people. Um, Despite the fact that it's not obvious to other people, the lived experience of the person who has it is impairing. It does impact their lives. In other words, it's not that we just go like shopping around at Walmart and be like, you look autistic. Can I evaluate you over here on aisle 23? We're not doing that, okay? These are people who come to us because there is something that is different about them, something that is impacting them in ways that are significant enough that they're willing to get on a waiting list, shop around, and wait, and then come in and pay money to have this thing figured out. And so we listen very, very carefully to people when they come and tell us their stories. I know we're talking about kids today, but we have adult women who have come in with a 2-inch thick stack of papers of all the screening forms they have done, all the evaluations they have had, other things that they've been striving for, in some cases, years to get somebody to listen to them, to acknowledge their reality. And we were the first people who did that. And that's life-changing, for that individual, to be able to have that kind of attention and compassion. We don't make people come in here and look autistic in order to diagnose them. Okay, so anyway, good questions. Let's continue on because I do have a few other things in the slides, although I don't have a lot more slides. So continue, please continue asking questions because I would much rather do that. And for that matter, if some of you ask a question and you want to jump on here and talk to me, that's fine with me as well. I put this slide in here. I'm not intending to read this entire slide for you, but I made it available. This is kind of a pink flag slide for autism in toddlers. Okay. Um, and so as you can kind of see here on the left-hand side of the column, you've got different aspects of social communication, or different aspects of repetitive behaviors. And then on the right side, you've got what might be less noticeable, less obvious, what we sometimes refer to as pink flag kinds of things. Okay. And so just maybe let's just talk about maybe a few of these. If you look at, for example, just the top left corner, limited social engagement. So this could be just a tendency to not initiate much. Okay. Some children don't initiate much, but they might respond fairly well. So it could be kind of either of those two things. This one says rarely initiates or responds. Some kids actually respond relatively well, but they may not initiate. Okay. Um, and again, related to that, they might show inconsistent interest in peers or group activity. So there may be times when they show interest and engagement and others when they don't. One thing that's important to contemplate is, was it the people? Was it the environment? Was it the activity? Was it that the children at the time that the child seemed more engaged, they were doing something that was within the skill set of that child, and so they jumped right in, and they looked like all the other children in that specific setting. And then the other time when they were more disengaged, maybe it's the nature of the activity was required more language, required more cooperation, more reciprocity, or other factors, and so the child was more disengaged in that kind of setting. Um, let's skip over to on the right-hand side, selective interests. So they may, display a strong focus on a few toys or topics, um, but not necessarily to the exclusion of all else. In other words, this isn't the kid whose family's like, I'm telling you, we have every single Spider-Man toy known to man, and they won't play with anything else. Like that happens, right? I mean, I don't know about, what, depending on your experience, Thomas the Train is a common one that could be really any number of things, right? But some kids are like, yeah, they're really very focused on this one thing, and then they also have other things that they will engage in and play with, but they still show a hyper fixation or a heightened level of interest in one or more specific things. Um, and then one thing I want to mention on this slide as well is emotional regulation. So there's a broad range of ways that emotional dysregulation can look. Some children with autism are actually pretty mellow. They're relatively calm. They don't have big meltdowns. Um, and sometimes that's because they're almost too docile. So they're not advocating for themselves adequately when another child comes and takes a toy away from them, for example. They just kind of roll with it and move on and they don't assert. Does that make sense? And so they're not melting down, but they're also not engaging in maybe what we would think of as appropriate levels of assertiveness, for their developmental age, for example. But then you do have children who do overreact. Heightened levels of emotional reactivity often are an indicator of at least developmental delay, not always autism, but often there's some level of developmental delay and often associated with difficulties in communication. So that it could just be a child with some type of speech or language disorder, is hyper, has more emotional intensity, but doesn't manifest the other characteristics of autism, for example. Um, and so it is important to keep in mind that although we are looking for nuances and we're looking for sort of pink flags, and oftentimes we will see a clustering of pink flags but we're still looking for them to be across the different domains of that are specific to autism. So even though they're more nuanced, they're more subtle, uh, again, less obvious, they're present, is the issue. One quick thing let me say, and then it looks like maybe we have a question. I don't know, Colin, but um, one thing I wanted to say is people talk about the autism spectrum, um, and it's tricky because if you think of that as like some kind of rainbow or something, it can be a bit confusing. And so my preferred analogy is to think of a radio dial, a volume knob, if you will, and each characteristic has its own volume knob, and the volume goes from 0 to 10. If the volume is at 0, the child does not manifest that symptom at all. If it's a 1, they do. And it's really, really subtle. And it can go all the way up to 10 where it's flagrantly obvious. Does that make sense? And so that applies to sensory issues, that applies to emotional reactivity, that applies to the core aspects of autism in terms of social awareness, social reciprocity, communication, restricted interest, repetitive behaviors, sensory issues. Every single one of those little elements has its own volume knob. And because people are not static, our nervous systems fluctuate and change, frankly, from day to day, but certainly over periods of time. So the volume levels on those knobs can be adjusted. The question is it 0? Okay. And so sometimes it's like, is it 0 or is it 1? And it can be sometimes pretty pretty tricky to know if it's the difference between a 1 and a 0, but it's an important difference because those are the areas where we're trying to find, again, people who have less nuance or sort of more nuanced, less obvious presentations. Okay. Colin, were there any questions that were lingering? I thought I had seen something flash across there, but
No, it was the survey that's going out to the group.
okay. Just making sure. Um, so is that all I have? Yeah, that probably is all I have. So we've got about what's time is it? 15 minutes or so. Um, I know you guys are going to have a case presentation in a few minutes. If you want, I could share a couple of recent cases, or if there are other questions that people have, I'm happy to address those. I swear I had more stuff on my slides. What did I miss? Oh, you know what's missing?
Actually have a question for you if you
Um,
have a second.
Feel free to ask questions. I thought I had some material on a slide talking about identifying providers, but I don't see it now. Dang it. Did I lose those slides? Uh, I apologize. I know I created a
No,
few.
it's there. I think you missed it because it looked the same as
Oh, is
the
that what
s-
happened?
yeah, it's right before your name slide.
Thank you. Um, oh, thank you. Sorry about that. Um, I'm a bit out of practice when it comes to doing these things. Give me a moment here. Let me reshare that. Um, Thank you for helping me see that. Okay, so let's try to start that. Are you seeing my full slide or will be shortly? Okay. So I gotta go one more, I think.
Yep,
Ah,
right there.
this is it. Yeah, thank you. Um, so a couple of things, when you're looking for providers, obviously you want to have providers that have specific training in autism. We are not yet at the point in the field where most mental health professionals are ready, to take referrals that are specific to autism, um, and and so I think that is important. Um, I mean, I guess if you've got a person, maybe it's a psychologist who's like, yeah, I don't really specialize in this, but I can diagnose obvious cases, okay, that's a place where maybe you send your obvious ones. Um, what I sometimes sort of irreverently say is the obvious ones can be diagnosed by a Walmart cashier, right? And so you don't need any training, in to diagnose those kids. However, it's not that it's unimportant, for the person diagnosing them to have a good level of understanding and knowledge of autism so that not only are they getting diagnosed, but also are receiving additional supports and services and things like that. Now, because I think many of you, that's your field is, yeah, we're the support folks, you know what I'm saying? And so if you're like, listen, I just need this kid to have a diagnosis of autism, and I know that this psychologist will recognize it, send it, and then you can be like, give it back to me. I'll connect them. I'll worry about connecting them, which frankly, those of us, even those of us who do, um, understand the more nuanced cases, it's very helpful for us to have you all, out there and being able to say, yeah, I'm going to connect them in over here and over there. That's super helpful for us, and I think we've received referrals. I'm sure from some of you, and we appreciate those, and that collaborative relationship is very helpful for us. Colin, you had a hand raise.
Yeah, and I think this question kind of dovetails with what you were just on right there. Um, how do the results of your evaluation typically appear? Is it more of an ASD diagnosis versus not diagnosed, or can it be more nuanced than that?
It's a good question. So uh, the each evaluation that we do, we strive to be comprehensive in the evaluation process, and so we're not just looking for the diagnosis. We do enough evaluation, frankly, so that we have a really good understanding of what the child or person's levels of functioning are across multiple domains. And so, usually, depending on the age, in the toddler, we're not giving them an IQ test, but we will give them some type of developmentally oriented assessment so that we have some level of understanding of, language or communication skills, adaptive skills, cognitive ability, things like that. At least something that gets us in the ballpark of where they're at. And then doing autism specific assessment, usually ADOS or CARS, or both sometimes, and then maybe rating scales like ASRS or SRS, Vineland, other sorts of assessments, so that we really have a clear picture of the whole, of that child or that individual. And then, of course, all of that gets compiled into a report. The diagnosis itself, is going to say autism spectrum disorder. Um, and then level one, two, or three. One thing I do want to just say about levels, and there's not much data, frankly, in terms of the levels. One of the reasons why the field got away from calling it autism or autistic disorder and high functioning autism and Asperger's disorder is because and PDD-NOS, which was 15 years ago, if some of you are newer to the field. uh, the reason they got away from that is because in the community of providers, they didn't have consistency in terms of what people were calling what. So you had some kids who had just like, Walmart cashier level severe autism. They were being diagnosed with Asperger's disorder, for example. And so it was just really inconsistent. And we have similar levels of inconsistency right now, I think, in terms of, is it a level one? Is it a level two? Is it a level three? What we tend to talk about with parents is, don't over preoccupy yourself with what the level is. First of all, the levels, you may or may not be aware, the levels technically don't even define the severity of the condition. They define the amount of support the child needs to function in the areas of social communication skills, and the degree to which they need support because they have repetitive interests or repetitive behaviors or restricted interests. And so the DSM does its best job with kind of this very loose framework of trying to quantify those things, but it's a very loose framework. So we will usually put a level on, but we sort of de-emphasize that specific element when we're talking about it with families. And mainly because the levels can change, especially where today we're talking about toddlers. I've definitely seen children who looked pretty severe at age 3, and by, age 5, they looked a whole lot better. So they're progressing, their skills are advancing. And so I think it's important to just understand that, you know, the level, if you will change over time. Hopefully, like that's kind of the point, right, of figuring this out early, is to push that developmental trajectory to the extent possible faster, so that those new skills are coming online, maladaptive behaviors are diminishing, and so forth. Does that answer that question, hopefully? Um, any other questions?
Yeah.
I'm happy to entertain.
Yeah, absolutely. We have Tony, who's the host, so she can't raise her hand. So she's going to come off mute and ask her question.
Great.
Thanks. So I work in a district preschool with a lot of kiddos with developmental disabilities. A lot of them we would have strong suspicions that they would be on the autism spectrum, but legally we can't say autism to parents. Do you have any advice or tips on how we could kind of nudge them that way to have a diagnosis without saying autism?
That's a good question. Let me ask you kind of maybe a follow-up question, then I'll address it. Is when you say you're not allowed legally, are you saying that you're not allowed to diagnose? Because certainly as an educator, you can classify from an educational perspective as autism, right?
And I don't know the exact ins and outs. Janelle might be able to speak to that a little bit better than I can. But we were just given guidance like through our school district that we can't actually say, we suspect your child has autism or we suspect your child has ADHD, anything like that. We just kind of have to give hints more or less.
Hmm. Yeah, I don't know. I mean, I think that's interesting. I do. You're not the only district that's doing that. We frequently have parents who come to us and they say, "Well, more or less, I think what they're describing, kind of what you're talking about. The school said that they have some concerns about our child, and then we think that the school thinks that we should have them evaluated. And then the school wants the report so that then they can act. You know, I want to be delicate about the way that I say this, but I'm not sure why that's the case. School districts have not only the responsibility, but should have the capacity to identify autism, evaluate it effectively, and classify children, at least from an educational classification perspective. Does that make sense? So I'm not sure why it is you're not the only district, like I say, that is doing that. Um, but I also recognize that in a district, you have to comply with what you're being told, from above. And so my suggestion would be, um, and this is kind of the way that we talk about diagnoses with families as in the process, is we'll identify what specific areas of concern are. Does that make sense? Like when I sit down to explain a diagnosis to a parent, what I will do is I will review with the parent what they told me in my interview with them, and I will review with them observations that I made in the clinic. And in this case, I'll also review the test data and things like that, right? That we've gathered in the process. So you could do probably close to that. You could maybe chat with the parent and say, "Hey, we're noticing whatever, here in the classroom. Are you guys seeing that at home, as well? We love Johnny or Susie, and they're fantastic. And we are noticing that they seem to have some difficulty with be specific. Does that make sense? And I think one of the of course, things to do is buffer anything that they might feel like is negative with something positive. Does that make sense? And state something that seems to be maybe, you know, a deficiency without maybe coming right out and saying they're deficient. You were just seeing they're not quite as far along as some of the other students. So we're wanting to understand that better. Can you help us, when you see them in their play with in everyday life, if they're going to other activities, maybe in the community or church, are you noticing some challenges with, engaging with their peers or whatever? Does that make sense? And maybe at least have that conversation. One of the things that I can tell you from this angle, is that um, I recognize that there probably are families who they're not ready to hear it, and so that's not a comfortable spot, to be in. And I assume educators probably find themselves in that spot more, right? And so, because what we usually get is, we're ready now, kind of a thing, like we want to know. And so, I think that gentle approach, of saying, kind of emphasizing maybe two or some of the strengths that you're seeing. And one of the things that we'll do is we'll talk about a strength and a weakness of the same basic skill at the same time. In other words, I might say, I've noticed that, when I engage them in a conversation about, something, maybe that's a preferred topic, for example, they can talk a lot, about that. And they shared a lot of details. It was very interesting. They were really engaged, and I can tell they really know a lot, they're very capable, about that. I've noticed that they're not quite as communicative or not quite as able to have that conversation if we're talking about how they feel about something, or if they're trying to problem solve a negative interaction with another child, for example. And so kind of keying in on a strength in that specific domain and a weakness at the same time. Does that make sense on that same skill? So I don't know, is that helpful at all, Tony, to
That
you?
is, yeah, those are some really great insights. Thank you. I wish we could be more open with our thoughts, but I think also a lot of it is like what you mentioned, that some of the parents just aren't quite ready, and some of them would have a really hard time with that possibility of a diagnosis.
Yeah, I do understand that. I mean, that's part of the reason why I put, on the slide on here. It's like you know, what are the benefits? It's really probably better to talk about not what are the potentially awful things that would happen if the child's not diagnosed, but what are the benefits that come, from that. Um, one of the maybe let me share one more thing, and that is, it's not very often at this point that I have a family come in who's not ready for the diagnosis. Most of them are, but there are varying levels of readiness. But one thing that I like to say to somebody when I feel like I need to share something that might be difficult for them to hear, is I'll say, I need to tell you something. It feels to me like I would be dishonest with you if I didn't share some of the things that I've been observing, and I'm a little worried because I really am afraid that I might offend you, or that you might think that I have something negative about your child or whatever. Does that make sense? But it's really not that. I just feel like I need to be honest with you and share some things that I've noticed, yeah, while I've had, your child in my classroom or whatever. Does that make sense? I've never had somebody say, I'm so mad at you for being honest with me. You know what I'm saying? Like, just not a thing, So anyway, maybe that's another one if that's helpful to you.
Yeah, that's a great approach. Thank you so much for that.
Sure, you bet. We're nearly out of time. Any other last minute questions from anybody?
Yeah, there was one more, and this is kind of a complex one, so bear with me as I try and sound out some of these words. Um, I am interested in your framework and how/if you are assessing primitive reflexes and orofacial myofunctional disorders as a comorbid diagnosis.
Hmm. Yeah, unfortunately, I'm not trained in that. Most psychologists aren't. I'm aware of those kinds of things, and I do think there actually is some value in understanding primitive reflexes and things like that. Basically, what they're asking, Colin, is awareness of the fact that it's not just social and communication, and repetitive behaviors, but some autistic children, and frankly, even older, people, they do still have overreactive nervous system. And that can be among the triggers for a negative emotional reactivity and things like that. And so they startle more easily. There are a number of them. I don't actually have as much knowledge in that particular area, as it sounds like this person probably does. Many occupational therapists, I shouldn't say many, there are some occupational therapists who have quite a bit of knowledge about that in that particular realm. And some really cool things have been done to sort of essentially, I think I don't know the terminology, but I think they talk about sort of trying to integrate those primitive reflexes so that they're not having them. Basically they sort of become more of sort of an integrated nervous system, like it kind of quote unquote should be, and that just improves the child's overall sort of functioning and reduces their reactivity to things in the environment. So that is a fantastic question, and I do think it's an area that's helpful to be aware of and to remedy. So I think we're about out of time. Any other, let me just pause and say, again, I want to thank Colin for inviting me. Thank, the team for, inviting me to participate and kind of be with you guys today. Um, if you have patients that we can be helpful with, we're happy to help. We've seen people from every part of the state. I've seen kids from Logan to St. George, from Vernal to Wendover, and so we see everybody. And so I'm happy to help. With cases, like I say, I just would ask you, don't put me on a list that goes out to large numbers of providers if you can help it, because there's just two of us, you know what I'm saying? And I would really not, I don't want to have a 9 month wait. So, but you guys know, and so feel free to, and you can share it amongst yourselves. Just don't put it on Facebook, don't put it on Instagram. Like we don't have a Facebook page, we don't have an Instagram. And believe me, we have plenty of work to keep us busy. But part of our goal is to keep that wait time down. Does that make sense? So that people aren't getting told, yes, we'd be happy to see your 2-year-old child 9 months from now after they've missed out on 9 months more of services, right? So anyway, thanks again for letting me be with your group today. I appreciate it.
Thank you. I really appreciate it. I also loved your analogy of the less subtle signs with the volume knob. So the 1 to 10. So even if they have it, they still have it. It may not just be as loud. So I really appreciated that. That was a great um, side of it. And also that taking away that wait and see approach. So pushing that level of developmental trajectory. I mean, that's ultimately what we hope, right? Like that if they get into early intervention, part C, that we're making a huge difference so that by the time they get to the school district, they are looking a whole lot better developmentally. So thank you for those 2 points. I'm going to turn the time over to Joe, who is doing our case presentation today. So, Joe, if you want to come off mute and share your slide.
Yeah, let me get it going here. Just a second. Is it coming up? Okay, can everyone
Yep.
see this?
Yes. Oh, no, not
Oh,
now. Yes.
now? Are we there?
Yep. Yep.
Okay. All right. So, as I said, I'm Joseph Patterson. I have my master's in behavior analysis, and I work for a company. It was early intervention called Kids Who Count. And I work with a little girl. We're going to call her Hope. She's 34 months. She's going to be turning 3. She's actually 35 months now. She'll be turning 3 next month. I've provided services in the community, in the home. We've gone to parks. We've done stuff here at the clinic. Um, she's been working on distress tolerance, communication skills, responsive skills. And in fact, Dr. Edgington's presentation was actually really good because I have concerns with some of the stuff he talked about. The culture that we see is this is an English family. They have 4 kids. She's the youngest by far of all the kids. The parents are very informed. They do research on their own stuff. They learn about new ideas. They talk to people. They practice strategies. We've talked a lot about some of the stuff that we see. Some of the primary concerns of the parents that Hope is not responding to her name. She is not making eye contact as much as they would like her to do. She does communicate, but doesn't communicate frequently with them. She does have her little phrases that she says. She can count. She can name colors. She can follow Miss Rachel on videos, but when communicating with her parents, she usually goes to pointing or dragging them to places. We've had a lot of talks about autism. The biggest thing that's keeping them from her getting tested is the mom doesn't want her daughter to be labeled or put in a box or seen differently. So even though we've talked about what's good, we've talked about what the possibilities are, and I've worked in that field of many years with ABA therapy and kind of shared some of the stuff that we've been doing as like a little watered down portion of it, not too in depth. But she still has that fear that the world will see her differently. But some of the things that we're seeing is she's having a lot of tensions because of her communication. She's not listening to her family when they are talking to her. She's not responding to her name. Eye contact isn't there. We've done many things like using a mirror for eye contact, so she's not really looking at the person, but from a reflection. We've done it with toys, we've done it with goodies, we've done it with many different strategies on trying to get approximations, looking at pictures. There's not that desire to look or respond to those names. Some of the goals that we have been working through is that Hope will follow 1-step commands, and then how that they'll know this is done in 6 months by doing those. And then during meal times, Hope will try 5 new foods or request items she wants through communications of pictures, signs, words. She is eating better, but that once again, that communication isn't quite there. She's just not doing it. Some of the barriers is, like I said, not responding to her name, following simple directions. She's not using her words that she knows. Um, she likes to have her toys arranged in a certain way. She does let you participate, but after a few seconds of you doing stuff, she'll take that item you put down, look at it, put it aside, and then go in the direction she wants to. So she doesn't get upset with it, but she just corrects it on her own and takes her own way with stuff. She does like to play with other kids as she's getting more into that. However, she still prefers to go off and do her stuff on her own and do her own things. Um, we did recently get her into our play group here at Kids Who Count, and she is getting more familiar with other kids and participating and sharing, sitting down for reading time, sitting down for snack time, so getting used to that type of stuff. However, we're still the responsive to her name and all those big concerns are still not happening. Um, some of the other stuff, like I've said, she's says colors, says her names. The strategy we use, like I said, are mirrors, looking at faces, using a candy, pointing in a direction. We tried doing fun games that she likes to do and participate in those and showing good directions with that. But then after like a few seconds, she's just done and walks away. For language, some of the stuff that we've done is we've explored using pictures. We've tried doing echolalia. We've tried to do a choice preference between two items. We've tried, right now we're trying to teach her little phrases that she can do, kind of like a reverse language learning of little phrases that you can say to that she can use, but she's not using that towards her language development and communication skills there with us. And so a couple of questions that we have that we want to know is what are some strategies a family can use to encourage Hope to be more comfortable in her language communication? And then question two is what advice would you give the parents who are hesitant or scared to get their child tested, and what benefits would come from doing that, like Dr. Edgington shared with us, and how can we hope feel more comfortable responding to her name and being reinforced with that response and her learning what can go from that. But yeah, that's my case. Like I said, she's going to be 36 months next month, and so she's going to be transitioning to the school district. So just want to get some ideas on how we can help her and her family as they transition to this new area, to be more comfortable and stable with stuff.
Great. Thank you, Joe. We will be moving Joe in between the breakout groups, so you'd be able to ask him questions when he gets to your breakout group. If you are in Colin's group, you guys are going to be addressing question number 1. What are some strategies the family can use to encourage hope? If you're in Maddie's group, what advice can you give to the parents? And if you're in Stacy and Justin's group, how can we help her feel more comfortable responding to her name? So Tony's going to go ahead and open our chat, our breakout rooms. Please take a minute to introduce yourselves, where you're from, and then assign a note taker. Right. Everybody should see those. Hi, welcome back. I think that all the breakout groups are closed. So for our next little minute, we will just go over one idea from each breakout group. So Colin, I'm going to start with your guys' breakout group. I don't know who took quest notes.
I did. And boy, one idea that's going to be hard. So comfort is the biggest thing. So we said perhaps using sign or pictures to help us start an exchange of communication. And then that actually sign can help them communicate verbally later on.
Great. Okay, then we have Maddie. How about one idea from your guys' group?
Um, just for the group, the question that we had was, what advice would you give to the parents who are hesitant and scared to get their child tested, and what benefits would come from doing that? We really focused on the label of autism and why that's a concern for mom. And maybe, diving in deeper to better understand what her fears are with the label of autism, and kind of validate her in her feelings and understand where she's coming from. And Rihanna and Trudy both came up with some really great points of, if you don't have, that autism diagnosis and that possible label, what other labels will your child get? Like the problem child, the difficult child, and so on.
Yeah, great points. And then Stacy, what's one idea from your guys' group?
I took notes so I can
Okay.
Um, so one of the biggest thing that the theme that we had was just always associating her name with something positive. So if mom had like a preferred toy in her pocket that the child loves, anytime, or a snack or whatever, anytime that the child does respond to her name, immediately giving her that reward, or always associating her name with some positive interaction.
Great. So if you all will send those to the Autism Echo at usu.edu, Joe, we will compile those and send those out to you, as well as for everybody on the call. They will be on the Canvas page, so you are always more than welcome to go and pull those recommendations and resources that were shared in those small breakout groups. Thank you all for joining. Again, our next session in December is December 19th, and it is a Thursday because nobody wants to work on Christmas, and that is when this lands. So we are moving it to a Thursday. So hope to see you all in December. Thank you. Enjoy your Thanksgiving dinner tomorrow.